Good. So now it's recording, and I would like to say hello to all my friends that are looking to me here, watching to me. I saw Hatije here. Hello, Hatije. I miss you so much. Manu is here, and many other friends. So thank you so much to be here. And we had a problem with the YouTube, but we will make the recording and later we put on the YouTube in the same way, okay? This subject is extremely important, and all of you know that I have been dealing with the possibility of advising people that it's necessary to think about malocclusion far beyond the teeth. Because when we think about malocclusion, only paying attention on the movements that we can or we cannot make on the teeth, that we must do or not, early interventions or not, focusing only on this, we miss a lot of important things, and we can create for our children a lot of problems that we can avoid if we make the correct diagnosis and the correct intervention. Sometimes very little and simple interventions can prevent very important problems. So I would like to say that if there is an agreement that functional stimulation is crucial for bone shape determining, because this is something that many people doesn't think about. Bone doesn't have the memory of shape. The shape is given by the stimulation that the bone suffers, okay? It's extremely important to understand that bone doesn't exist without loading. So the loading is the most important part of the establishment of the shape of a given bone. So it is extremely important to put this in mind when we are thinking about early intervention. So it is necessary that everybody understand that therapeutic interventions must be done as early as possible when any single alteration is detected. We are not supposed to wait because we need to pay attention in the things that are around the teeth, not only on the teeth, because the position of the jaws interfere with a lot of functioning, okay? Interferes with the establishment of good working of many systems, not only stomatognatic system, because the stomatognatic system is related to all other systems that we have. So my aim today is discuss exactly this. So I want you to focus that tooth is not the center of the universe. So we have to understand that we must put our attention far beyond the tooth, far beyond, because it is not in the middle of our way of working. No, we have to understand another way that tooth is an important member of many interligated systems, okay? So the connection of superior and inferior tooth, the occlusion, is a small system when we consider all the others that are involved on the interrelationship between superior and inferior jaw. So when a baby is born, they don't have teeth, but the relation between superior and inferior jaw are extremely important for the function, to breastfeed, to swallow, anything. So we have to remember the functions from the stomatognatic system, okay? Well, I think that there are some statements that we have to make. We must forget this alignment. We can align this even if the patient has 80 years old. So put this in your mind. Forget alignment of this. We need to understand that functions determines form. So we have to focus on the correct execution of the functions, okay? We must understand that occlusopathies, what does it mean? Any alteration on the relationship between superior and inferior jaw, not with this. Any interference on this good relation leads to altered stomatognatic system functioning. And as I said, stomatognatic system is related to all other systems. So we have to pay attention on that. And we have to understand that correcting an occlusopathy as early as possible allows the children to develop in a perfectly way all the 5 senses. Have you ever think about that? That all the senses are related to this region? Start to think, and I will show you now how relevant is this, okay? So when we start to think from the beginning, from the fertilization and the formation of a human being, we start with 2 cells, and then we finish with a complete human being that will be born and having the connection of all the structures of that new wonderful body that finished to be completed. And we will start to get mature, to develop, to evolve, and to well develop. We will need to function in a correct way, trying to achieve the plenitude of all the functions. And if we achieve this, we will have the possibility of a perfect growth. So if I have a cut, if I make a cut on this region of a small embryo, and we start to focus only on this region, what we will have here? I want you to draw your attention for that. Here is the first branchial arch. When we studied this, we lose many things that was necessary for us to understand. So we have here the first branchial arch divided in 2 parts. The yellow one is the part that will give rise to the mandible, and the blue one is the part that will give rise to the maxilla. And here we have the frontal nasal process, okay? That will give rise to the anterior part of the maxilla. Let me show myself to you. Well, so we have these parts forming to give rise to a stomatognatic system, but let's pay attention on the relation of this with other parts, okay? So here we have the frontal nasal process, okay, prominence, that will give rise to the anterior part of the maxilla, and in the blue, the maxillary branch from the first branchial arch that will give rise to the posterior part of the maxilla. And here in yellow, we have the branch of the first branchial arch that will give rise to the mandible. Well, now I start to show you something extremely important. Look here, what is this? Is the nasal placodes. So in this region, we will have the nose forming, okay? And the nose has 2 important functions: to breathe and to feel smelling, okay? To smell. So 2 important functions. Here, you are seeing a small placode that will give rise to the ear. And this placode will move up until the end of the first branchial arch. And here you are seeing what? This is the optic placode that is formed where? Inside the maxilla. Have you ever think about that? That the eye was formed inside the maxilla branch? Have you ever think about that? Well, if you see here, you realize that the maxilla moves and the eye placode move together. And here you are seeing that the ear placode goes up and it is in the end of the first branchial arch. Here we have the nose that will be forming, allowing the breeze and also allowing the smelling. Okay. Now, this part of the skull goes forward and make the eye go inside, but is still related to maxilla. Now, we have the ear up in the end of the first branchial arch, and the nose is finishing the forming. And in the end, we have all the structures connected. So we have here vision, we have here hearing, we have here olfaction, we have here gustation, and also touch, because the touch, that is one of the most important sense of the human beings, are extremely well developed inside the mouth, okay? And it is going to develop all of them together. All these sense and the system that are related to the sense are developing together. It is extremely important. So from here until now, so when we have complete formed human being, we have all the senses here, remembering that here we have gustation and extremely developed sense of touching, okay? Extremely developed. So when Aristotle described the five senses, he was never paying attention on that, but we must, because we work here and we know now that this is completely related to the others. So we have to pay attention on that. So let's start to think on the senses executors. For that, we must remind some important concepts. So, cranial nerves versus craniofacial complex. Have you ever think about that? Let's list the cranial nerves and start to think if all of them are related to stomatognatic system. Functional orthopedists and also periodontists and people that deal with growth and development must know it very well, and better than know, understand very deeply the interface among all the cranial nerves and the craniofacial growth, because there is a very important interface among all cranial nerves and the development of stomatognatic system. So here we have all cranial nerves. So we have the olfactory, optic, oculomotor, trochlea, trigemium, everybody remember the trigemium, okay? Then abducent, then facial, vestibular, cochlear, glossopharyngeus, vagus, accessory, and hypoglossus. So all of them are related to the mouth. Yes, all of them, okay? We have some that are only sensitive nerves, we have some that are only motor nerves, and we have some that are hybrid, and all of them are related to this region. And we have to understand something extremely important. The trigeminal system has a huge connection with all the other cranial nerves, and also with some spinal nerves that comes from here and connect with the trigeminal system, generating the inputs and the outputs that we need to functioning, okay? So we must understand that our profession must be understand far beyond the teeth, because the relevance of any single point that we make in our stomatognatic system will have a reflex on the functioning of all the other regions innervated by the cranial nerves and some spinal nerves. So let's start to think about vision. Is there an interface with occlusopathies? Let's start to think about that. Many time ago, I started to think about that, and I went to the literature to find some connection between vision and stomatognatic system. And here I make a small list about some things that I start to find 3-4 years ago. So first thing, orbital shape can be deformed by malocclusion. Have you ever think that the maxilla is related to all the bones that makes the orbital? Yes, I showed you that the eye is formed inside the maxilla, so we have to pay attention there. Transversal asymmetries can lead to convergence problems. Oh, if I have transversal asymmetries here, the convergence of the eyes can be altered. Wow, I never think about that. Yes, but you must. Class 2 patients, the patients that has the maxilla in front of the mandible. Class 2 patients are more prone to myopia. Class 3 patients are more prone to ocular motility disturbance. Unilateral crossbites enhance the probability of astigmatism. Wow! But astigmatism is a irregularity on the surface of the orbit. Yes, but we have many muscles that connect to the surface of the orbita, and we have some that have connection with the trigeminal system. The oculomotor system has a connection with trigeminal system, and they can alter each other. And also, if I have an orbita with a shape altered, we can have the muscles of one side working different from the other, because the attachment of them are completely different. So start to think on that. Exaggerate ocular dominance can lead to head rotate posture and positional mandible deviation. So on this case, what I am talking about is something completely different, because I am talking about some alteration on the vision can generate a malocclusion. Are you crazy, Patricia? No, I am not. Imagine that you have a very high dominant eye. So the dominant eye is the eye that we use to shut. Okay, imagine that you have a right eye with a huge dominance over the left. So you tend to put this eye more in front, okay? So you deviate a little bit your head to the left to put the right eye in front. So to compensate this, the body make this, deviate the mandible to the opposite side to equilibrate the chains of muscles, okay? So you deviate the head and the body, the brain send a message for the mandible to deviate to this side. So you can generate a crossbite because of eye problems. Wow, so I am telling you that we have a double direction problem. So malocclusions, occlusopathies can create problem in the eyes, and eye problem can create malocclusions. So the reference for this is here, and this presentation will be on the YouTube, so you can check what you want, all the reference, and go to the literature. But I will show you also that I myself have some publications that are free, and you can take them from the internet, like this one. In 2018, I decided to make a mini review and publish in the journal, ophthalmology journal, okay? And I call it the paper, Where Mouth Meets Eye, because I would like to draw the attention of ophthalmologists also to this connection, not only dentists, but also ophthalmologists, because we must work together. So I published this, and because of that, I had an invitation from a group from Italy, and we made our work in a school near Rome, and we published last year this work. And this is a very interesting work because we made a very nice statistical study, and we have this. Bite and sight, is there a correlation? We made a clinical association between dental malocclusion and visual disturbance in pediatric dentists. And we find very interesting results. But we need to understand how it can happen, okay? How alterations on malocclusion can generate this. Then I will show you a movie that was created by a friend of mine from Brazil, just to be didactic, okay, to understand what happened. Just in a case, he suggested a hypothetic unilateral mastication, and you can understand what will happen to the orbita. So he is showing the maxilla, and now we will make a unilateral mastication. So the force generated on the maxilla will be completely different from the others, okay? So what happened to the orbita? Will distort, will have a huge distortion. And if the orbita has a distortion, the vision is not perfect. That is an asymmetric situation from right and left, and we can generate many different alterations. It's just an example for you to understand better, okay? Well, before going to hearing, I would like to reinforce for you something extremely important. The orbita finishes the formation around 7 years old. So due to that, it's extremely important to understand that to prevent the enhancement of the prevalence of malocclusion, of eye problems, vision disturbance in children, we must work early, because after 7 years old, the orbita finishes the formation. So we will not be able to prevent anymore the elevation on the prevalence of vision disturbance. So I would like to reinforce too much that I am not saying that all the visual problems are generated by occlusopathies. What I am reinforcing, and we prove it, is that occlusopathies enhance the prevalence of all vision problems: myopia, hyperopia, convergence problems, astigmatism. When I say convergence problem, I am reinforcing strabism, because some malocclusions can elevate 4 times the prevalence of strabism in our children. So if we correct the malocclusion early, we diminish the prevalence of visual problems. So we have to put this in our mind, okay? We are responsible for that. We cannot wait. We can treat this in all age. It's not a problem. I am not talking about this. I am talking about the development of the system. So we must start as soon as we detect. So let's go to hearing. Is there an interface with occlusopathy? So let's understand how the hearing is generated. So we have here, so we are seeing the sound comes here and moves all the ossicles. I will show again. The sound comes here and moves. This is the tympanic membrane that moves the ossicles of the ear, okay, hammer and incus, and here is the stapes, okay? And after this, the stapes transmit the sound to the inner ear. But here on the middle ear, where we have the ossicles, we have one muscle that is innervated by the trigemina, okay? We have a ligament that comes from the malleus, okay? The malleus, the first ossicle, malleus. So one ligament comes from the malleus, pass through the petrotympanic fissure and goes to the posterior region of the disc of the temporomandibular joint. So we have a huge connection between ear and temporomandibular joint, because on the beginning of the formation, on the embryologic period, there was no division between ear and temporomandibular joint. It was all connected, okay? So the interrelationship is too big. And we have to remember also that the 2 first ossicles of the ear are the end, they are the end of the mercal cartilage. Do you remember the mercal cartilage? That was the first primitive mandible. When it involutes, the end of the cartilage doesn't involute and transform to the first 2 ossicles of the middle ear, okay? So it reinforces the interrelationship between ear and mouth, ear and temporomandibular joint. So there is something that we call middle ear myoclonic disease. There is a problem created on the tympanic tensor muscle that is innervated by the trigemina. When you have a very big afference of problems carried by the trigemina, you can have an efference that doesn't come only to the muscles, masticatory muscles. They come also to the tympanic tensor muscles, okay? And they can contract in a wrong way due to wrong afference, and they can interfere with the capacity of hearing, okay? Also, when we have a trigeminal hypersensibilization to a big number of afferents coming from here because we have alterations on functioning here. So the trigemin is hypersensibilized, and this generated efference that we don't want, and that can create alteration on the functioning here. Also, we never can forget the malleus mandibular, that is this ligament that I told you that connects the malleus with the posterior part of the disc. And when we have alteration on the biomechanics of the temporomandibular joint, we can have this ligament tensioning, and we can have impairment of the correct hearing. So it's not Patricia that is saying, okay, it is in the literature. I'm just trying to open your eyes to this. It is extremely important to understand this. Here we have a picture. Imagine that we remove the tympanic membrane. Here it's remove it, and we can see the middle ear. So here is the malleus that was connected to the tympanic membrane, and here is the tensor tympanic muscle. This muscle is innervated by the trigeminum, as I said to you. So when we have afference coming from the central nervous system to the masticatory muscles, we also have efferences coming to the tympanic tensor, and we can impair the correct functioning of the ossicles. So since the ossicles have to vibrate to transfer the sound, we can have some impairment on the transference of the sound. So here is a cut that was made here. I want you to pay attention. Look, we cut here and remove the disc. We are seeing here the condyle. The disc was removed, and here is the malleomandibular ligament that comes from the malleus, that is in the middle part of the ear, the malleus, pass through the tympanic fissure that is here, goes inside the temporomandibular joint, and connects to the posterior part of the disc. We are not seeing the disc because it is removed to show us the condyle here. So when this condyle moves in any direction, it tensions the malleus mandibular ligament. If it's moving in a regular way, no problem. But imagine if you have a crossbite to this side. So this condyle is stretching in a different way, not normal way. So the malleomandibular ligament will suffer different type of tension. Okay, it can happen in child and also in adults. In some case, when the petrotympanic fissure close completely, it cut the malleomandibular ligament in some adults. But in children, always we have this passage, always. So we have to pay attention on that. If we have a crossbite, a protrusion, anything, the condyle moves inside the temporomandibular joint for one side, another side, front, back, it will alter the way of tension that the malleomandibular ligament is making on the malleus, and the passage of the sound will be disturbed. So please, it's not Patricia that is saying. It is on the literature. We need to read, we need to study, we need to go to the literature to support our practicing and to understand that we are dentists, but we are able to understand more than only this. And we have the responsibility of understanding far beyond the this. Please listen to me, okay? And how about olfaction? Is there interface with occlusopathy? Which cranial nerve is responsible for olfaction? When I ask this, everybody will say, I know, it's olfactory. Yes, of course, olfactory is responsible for olfaction. So we have here a picture. We are seeing this magnification here. So here is the olfactory bulb, and we have many nerval fibers here that goes to the mucosa of the nose, and these receptors here are able to sense the molecules that are on the air, and we will have the possibility to sense the smelling. So it is called ortho-olfaction, ortho-olfaction. But nobody teaches us that there is also a hetero-olfaction. The hetero-olfaction is under responsibility of the trigemium. So if our trigemium is not working properly, we will not have a correct olfaction. And the fibers from trigemium that sense the smelling are behind. So they are completely dependent of mastication. So when you masticate, you liberate some molecules that will be spread on the air inside your mouth, and these fibers of the trigemium will catch it and connect it with the olfactory catching and send to the brain, and the complete understanding of the smelling will be made there on the brain, connecting both afferents from the hetero-olfaction together with the ortho-olfaction. So if you don't have a good masticatory process to liberate a lot of particles, and these particles, these molecules, impregnate the receptors that are innervated by the trigemium, we will not have the perfect sense of smelling, okay? Of course, related also to the gustation, we will see it. But it is extremely important for you to understand. So, to good smelling, we need, of course, airflow going through nose. So it's important to breathe by nose. It's important to have the action of olfactory nerve, trigeminal nerve, glossopharyngeal nerve, and facial nerve. All of them have to be working together. But the most important are the olfactory and the trigeminal, because they are responsible for the ortho-olfaction and hetero-olfaction. It's clear for everybody the interface between oral breeze and malocclusion. No doubt about that. Everybody knows this. If the patient doesn't breathe by nose, will create a lot of problem. There is no doubt about that. Here, we want to enhance the discussion. We want to go far. We want to understand how malocclusions can interfere with olfaction. So all the molecules have to go into the nose, impregnate the olfactory receptors, and also impregnate behind the trigeminal receptors, mainly when we are triturating the food and liberating molecules that will be on the air inside the mouth. Never forget this. We need both functioning well to get the complete sense of smelling. So, trigeminal and olfactory system are close related, and alterations in one generate wrong functioning in another. In human beings, like in animals, olfaction has a role in defense reflex And this reflex is completely dependent of trigeminal afference. So the afference, okay, that comes from the trigeminal and from the olfactory nerves are also important to some psychological reaction. So it's extremely important to understand this. The body works in a complex, unique system, okay? Many systems connected in the complex, unique, and wonderful system. It's not possible to sense an odor in plenitude if the trigeminal afferents are not present. Heteroolfaction is extremely necessary. Of course, the olfaction will be perfect only if the air influx is coming totally by nose. We are not discussing this, okay? My aim today is to draw your attention for the other question, that is olfaction, okay? Nose breeze, there's no doubt that we need it, okay? So the references are here if you want to check them. Now, is there an interface of gustation with occlusopathy? If I have an occlusopathy, the gustation will be working inadequately. So first, we need to understand the sense of gustation that we have. So we can sense acid, salty, sweet, bitter, and umami. Have you ever think about that? Have you ever heard about umami? The ones that loves Oriental food, like Japanese, like Chinese, like Korean, like Thai food, the ones that like it, for sure, they know what is umami. Umami taste was described by a very important man called Kikunai Ikeda. He described this in 1908. And it was recognized by the science only in 2000. So why is so difficult to people to change paradigms? And I like so much this example because it reinforced to me something that I am always saying. We need to change paradigms. We need to change our old paradigm that we must wait to treat malocclusion. No, we cannot wait. We must treat as soon as we detect, because if we don't treat, we are convicting our children to have many different problems. It's not a kind of alignment of this. Please, we are convicting our children to have their systems not working in a plenitude of function, okay? So I always show this example of Kikunai Ikeda because I think it will delay almost 100 years like him to people understand that we cannot wait to treat malocclusion. But we can start to change some minds as we have the scientific support to discuss in a good level with everybody. So, to perfect perception of flavor, what is necessary? First, adequate olfaction. So the trigeminal has to be working properly, olfactory has to be working properly, and the airflow must be passing through nose. And we also need optimized chemical contact of the food and gustative papillae. For this, we need a perfect mastication. If we don't have a perfect mastication, we will not have a perfect sensation of the flavors because the molecules will not be liberated from the food in a correct way. So the impregnation of the receptors will not occur. okay? And also, we need an adequate functioning of salivary gland because we need the saliva to make an efficient food dilution, to optimize the contact with the papillae, the gustation papillae. So to have this, we have all the systems functioning perfectly. So imagine that we have the parotida functioning that is innervated by the glossopharyngeus. And we have the submandibular and sublingual that is innervated by the vagus. But the trigeminal system interferes with the afferents and efferents that is generated from these salivary glands. So if we don't have the trigeminal system working properly because we have occlusopathies, we will also have problems on the complex mastication and on the liberation of the saliva. So everything is interrelated, okay? So pay attention on that. Is there interface with occlusopathy when we think on touch? I put here a finger because when we think on touch, everybody thinks that it's hand or foot. No, the sense of touch is in all our body, of course, and here we have a huge complex of touch sensing, okay? And we leave the touch for the end of our conversation because of that. Touch is one of the 5 senses proposed by Aristotle. However, some researchers later, many times later, divided touch in 4 other senses, okay? The first one is the somatosensorial system. So what somatosensorial system makes? Identify textures, volume, a lot of things in terms of physical properties, okay? The second is the proprioception or synesthesia. What is this? Is the body spatial localization capacity. So we have the capacity to send messages to our brain for the brain have conscience about the position of our body in the time and in the space, okay? So it's the second. The third is thermoception. So we are able to sense cold and we are able to sense warm, okay? So the thermosensation is one of the division of the touch. And also nociception, that is the perception of pain. So the touch sense is divided in 4 different ones. Let's discuss one by one. Sorry for some typing mistake like here. So touch is one of the 5 senses, but let's discuss one by one. The first one, somatosensorial system. So it has a huge relevance on the stomatognatic system. Imagine that when you put a piece of food in your mouth, you have to detect the volume, the texture, the size, okay? The characteristic of the material of that food. So everything will be sensed by these receptors that we have in the mouth and informed to the central nervous system. And it will elaborate that information to send back the efferents to work with that food, okay? We have to think about that. In the same way, when we put an appliance in the mouth of the patient, a removable appliance that occupy the space of the mouth, this sense will be extremely excited. And we need to understand this to make the design of our appliance respecting the limits of the somatosensorial system, okay? Well, The second one is the, oh, sorry, I forgot to remember. So perception of volume, texture, hardness of bolus interfere with deglutition process, swallowing process. Bolus preparation is completely different on proper functioning of the somatosensorial system, okay? Just to reinforce the first one. Now we go to the second one, that is the proprioception. Occlusion generates important afference for mandible posture establishment and as consequence, body posture. Have you ever think about that? Here is a picture of a book that I wrote with Dr. Vilma and Dr. Danilo, and I would like to discuss this with you. How does periodontal proprioceptors regulate posture, masticatory force, and elevators relaxation? Have you ever think about that? Well, but you are a dentist. How you don't know this? You work with this every day and you don't know how it is working, functioning? How the brain regulates the mastication force. So we have different types of proprioceptors on our periodontal ligament. The first one is called spontaneous discharge receptor. And this receptor stays 24 hours a day, sending information to the brain about the position of your mandible in the space. 24 hours a day, it sends. Since the mandible is extremely important on the mandible posture, is extremely important on the establishment of body posture, so it means that 24 hours a day, this proprioception on the periodontal ligament is working to establish a correct body posture together with other proprioceptors that we have on joints, that we have on the foot and in the muscles, doesn't matter, okay? So it's very, very important to understand this. So this spontaneous discharge is a receptor that we have on the periodontal ligament that is responsible for the posture of the mandible, okay? The second one is called terminal bottom. We have this terminal bottom connecting some fibers of the periodontal ligament, like that, okay? Some fibers here, the bottom involves it. Remember that receptor is the end of an axonal fiber, okay? So the axon finished with a receptor. So when we have this terminal bottom involving here, we have to remember that we have the axonal going until here. Well, when we put something in the mouth to bite, and let's suppose that I bite a piece of bread. So my tooth or group of teeth will be intruded inside the periodontal ligament, inside the sock, and the periodontal ligament will sense it. Imagine that 0.001 millimeter, doesn't matter how much. It is extremely sensitive. So it doesn't matter how much it was intruded. The periodontal ligament senses it through the terminal bottom and informs the central nervous system. So having that information, the central nervous system says, well, to that food that intruded the tooth inside the sock, or 0.001, I have to send the contraction for 5 fibers of the masseter, 20 fibers of the temporal, 2 fibers of the middle-pterygoid, anyway. So the brain will determine the masticatory force according to this, okay? It's extremely important. And sometimes it can happen that you have a huge intrusion of your tooth inside the sock. Imagine that you are biting bread and suddenly there was a stone inside it. So your tooth will be intruded inside the sock in a strong way. So that is another type of proprioceptor that is called the terminal ring that will sense it and inform to the brain, well, there is something wrong here. I was intruded very suddenly here. There is something wrong. So the brain sends immediately the message to the muscles, to the elevators to make them relax. They send an inhibitory order to the elevators. So we relax the mandible when we bite, something like that. Everything that I am talking about is occurring without our conscience, because proprioception is automatic, is working from thalamus down. We don't have conscience about proprioception, okay? After having this, when we bite a stone, when we have the conscience of this, we had relaxed the elevators before having conscience, okay? You can observe this. Well, and how temporomandibular proprioceptors contribute to it? Of course, we have here also some proprioceptors that regulate it in the same way of the proprioceptors of the periodontal. Because when we are born, we don't have periodontal proprioceptors. And when we lose all the teeth in a edentulous patient, we don't have more the periodontal ligament and the periodontal proprioceptors. So we need a complex system to work when we don't have the periodontal ligament. The periodontal ligament proprioceptors, they are the most specific and criterious proprioceptors that we have in the mouth. But we also have others working on the system to help them, okay? And they are in the temporomandibular capsule. Well, the second was the proprioception, and now the third is the temperature perception. So the temperature perception is also important for us because depending on the characteristic of the temperature, we can sense in a different way the food, and we can generate better or worse inputs to the brain according to that food that will generate our preference of food, okay? So we have always to remember something. When I have something more cold, it seems for us that is more salty. And when we have something more hot, it seems to us more sweet, okay? Pay attention on that. Also, the correct posture of the tongue and the movement dealing with hot or cold food interferes with the taste perception. So the thermal sensation will be related with the correct functioning of the tongue inside the mouth, the movement of the mandible, because the sensation of the temperature will be influenciated by the correct functioning here. Sometimes it's too hot, swallows quick or throw it up, but everything is important to create the correct input for the central nervous system to generate from there the correct outputs that will make the plenitude of the functions of the stomatognatic system, okay? The last one, that is nociception. Malocclusions, occlusopathies, can lead to pain in different regions related to posture, okay? So we can have pain because we are forcing in one side, we can have pain on the temporomandibular joint due to forcing in wrong posture. So the nociception that can be enhanced, not enhanced, the nociception that can be elicited by some occlusopathy will be transmitted by the nociceptors that we have in all the system, okay? And it will generate reflex that we don't want, reflex that will avoid this type of afference. So we can change completely the way of working of the system when we have some places manifesting pain. When malocclusions can be cause or consequence of sense development alterations. So everything that we discussed until now are in the literature. But I want to focus your attention for the publications, okay? Because I want to reinforce that it's not my way of thinking, never. As a professor and as a researcher, because I made doctorate to postdoc, not to state what I think, but to be able to go to the literature and find the support for the practicing of jaw functional orthopedics. I dedicate my life to that, to bring the support for the jaw functional orthopedics practicing scientifically. So I would like to show you now some papers that states what I told you now, okay? What I was telling you is exactly what is in the literature. So why it is necessary to make early interventions? I don't want to hear people saying for me anymore that we have to wait. We don't have to wait. We have to work in time, okay? So let's check the literature, what the literature is bringing to us. So this publication on 2017, class 3 leads to ocular motility alteration. So it is saying that occlusopathy is a cause of eye problems, okay? In 2006, so many years ago, we don't read. That's why we don't remember to think about that, because it is in the literature, 2006. Class 2 patients are more prone to myopia, okay? And our work now in 2020 quantified it. I would like to ask you to read my work, okay? Because we will enjoy too much the results, okay, in terms of number. Well, class 2 patients are more prone to myopia. It means what? Malocclusions creating eye problem, vision problem. Unilateral crossbite enhance the prevalence of astigmatism, 2006 also, okay? Again, occlusopathy being a cause of vision problems. Here, wrong trigeminal afference generated by malocclusions lead also to ocular motor system alterations. It can create altered torsional and vertical ocular movements. So, 2 publications, okay? One, 2017, another 2011, showing that malocclusions can cause vision problems. Well, very important publication, +1. The other, extremely important, both of them, 2015. Opening eye reflex is directly dependent of trigeminal proprioception. Wrong afference from masticatory muscles can lead to altered blink movements. Pay attention, sometimes we see blink problems and we think it's a psychological problem, something like that. And many of the times it is caused by malocclusion. Please pay attention on that. We cannot wait. If you are seeing a child blinking too much, check if there is a malocclusion, because sometimes it is a reflex because of misunderstanding of the brain from the afference of trigeminal and oculomotor. Pay attention on that. Again, orbitomasticatory syndrome is a problem that can happen very often in adults. Patient has visual perturbation during mastication due to wrong tension on temporal muscle. So the temporal muscle, okay, make a tension, a wrong tension, it pulls in a different way, some region here, okay, and it leads to some perturbation on the vision during mastication. So the person is masticating and seeing some spots, some lights, things like that. So it is published on 2016, again, malocclusion being a cause of eye problems. Here, what I said to you about the eye dominance. So what I said is here, and in this case, the alteration on the functioning of the eye is lead to malocclusion. So malocclusion is a consequence of alteration on the vision. Here is a Romanian work showing that occlusopathies have a positive correlation with hearing acuity diminishing. So occlusopathy being a cause of hearing problems. Occlusopathies can generate children tinnitus. Okay, so 2017. Again, occlusopathies being a cause of hearing problems. Recovering of vertical dimension enhance hearing capacity. Again, diminishing vertical dimension can lead to hearing impairment. Of course, because we change the tension that the malleomandibular ligament is making. Now you can understand this. Please pay attention on that. We have to treat malocclusion as soon as we detect, okay? So again, malocclusion being a cause of hearing problems. Olfaction can be compromised by wrong trigeminal afference generated by malocclusions, okay? And I am sitting here, 3 works, one from 2007, another 2013, and another 2011. All of them saying the same, okay? Heteroolfaction stimulation is extremely important to establishing, to the establishment, for I wrote wrong, to the establishing of individual food preference. It makes, it means what? Food preference are very important because we need to enhance the diversity of food preference of our children, okay? So the stimulation of heteroolfaction will enhance this maturation. If we have malocclusions, we will not have a heteroolfaction working properly, and it can cause a problem on the food preference establishment, okay? Altered proprioception of temporomandibular joint can lead to sudden malocclusions. If not treated, they can become real. So here is a problem of the sense, that is the proprioception is not working properly, so it can lead to a malocclusion, and In this case, the malocclusion was a consequence, but if we not detect it early, it can become a real malocclusion. It's not positional anymore. So we have to be aware of all these things. Finally, we have to understand that food preference will depend on sense stimulation when introducing solid foods to children. So it's our responsibility to understand this and to make these things in a correct way. So, considering the vision, look, colors. White, it's not Patricia, that is saying, okay, it's in the literature also. Colors. White colors makes the food seems more saltier. Red colors makes the seems more sweetest. Yellow seems more bitter, okay? Shapes, round shapes reminds us for more sweetest taste, angular for more saltier or sour. It means what? Offering food for our children with different shapes and different colors will mature the chewing process. So make smashing food that has no color, because you smash everything and it starts to be kind of brown, no definition of the colors. It will not enhance the preference of chewing of our children, okay? The chewing process will get mature easily if we offer in a different way. Well, hearing also, the noise caused by chewing crunch and fresh food influences the pleasure of chewing and the development of chewing preference. For this, we have to have a good working machine here. Crisp foods should be introduced as soon as possible to enhance this pleasure for our children. Imagine, does everybody here that is listen to me likes to chew popcorn if it's not crunchy? Of course not. The taste will not change, but the sensation, touch sensation and hearing sensation will be completely different. So we must offer for our children foods that has different types of crunchy sensation. Crisp foods are very important. Olfaction, the perception of aroma by ortho-olfactory and hetero-olfactory is a very important cultural component of previous experience. Example, vanilla aroma is associated with sweetness in Western populations and with salty in Eastern ones. Why? Because they are used to this. But when we have a children, we must offer some food with vanilla, salty food and sweet food, not only focusing on our preference. We must offer to them what they want. So the introduction of different flavors and the stimulation of hetero-olfactory by chewing as early as possible will act in a feed-forward process, inducing the children to chew more. And to chew is to function, and to function means grows properly, okay? So it's extremely important to incentivize the correct chewing of our children. Touch, the texture, not only of the food, but also of the utensils used to carry the food, interfere with the perception of flavor. And you agree with me, I'm sure. if you eat a food with a very thin metallic spoon, and you have the same food with a plastic half spoon, the sensation will be completely different. So use good utensils for your children, but change the sensation also. It will be good to maturate the perception. Foods that use half-a spoon lead to a different flavor perception when compared to those that use a smooth spoon. Food temperature interferes with flavor perception. We said this before. Warmer foods seem sweeter and colder foods seem saltier. The offer of food in different textures and different temperatures promotes a better establishment of the masticatory process. We need a good maturation of the masticatory process. Gustation. It would be the combination of afferents generated by all the other senses associated with the activation of taste receptors. It is of fundamental importance in establishing the physiologic masticatory process and consequent adequate functional stimulation. Summarizing, the interface between correct working of oral functions and the establishment of five-sense reflex support the necessity of early intervention when any occlusopathy is detected. So I will finish my transmission here, and I would like to say to you that this recording will be placed on the YouTube. Okay, unfortunately, we had a problem and we cannot make a streaming there, but we will put there later. And you will be able to share this with all your friends. And I would like to ask you to do it because we have to enhance this concept. We have to stop saying that we must wait to treat any kind of occlusopathy. We are not supposed to do it, okay? We need to treat as soon as we detect. And better than this, we need to prevent the occlusopathy to happen. So if we stimulate in a correct way, since the baby is born, we stimulate the correct breastfeeding, we introduce the food in a correct way, we will make the development of correct behaviors, the correct mastication, correct swallowing, nose breathing, everything, and maybe we will diminish strongly the prevalence of malocclusion to our children. So please think about that, and I will be very glad if we can discuss this in another opportunity, okay? Thank you so much for your attention. It was a great pleasure to me to have you here. Kisses from Brazil, and we see each other around. Bye-bye. I don't know if I have some question here. No. Okay. So bye-bye. See you later.